Okay, so you all know who I am now? Anybody not present in the first lecture sort of talk? No? I don't know. Okay, fine. We're good. The objective slide. Remember how on the first one we were missing the disclosure slide? Well, on this one, I'm missing the objective slide. So the objectives of this talk is first to give you a case. Then we're going to talk about understanding the different cannabinoids and understanding the endocannabinoid system, understanding the exogenous cannabinoids, so the ones that exist inside the plant. Then we're going to talk about some of the side effects, because we have to understand what the side effect profile is if we're going to understand the therapeutic benefits of it. So we'll talk about the side effect profile, then we'll talk about the side effects, and we'll talk about the benefits, the clinical indications, and some of the benefits to using cannabis. I won't talk too much about the interactions. I know you're all here for that, but we have Shirag, who will be giving the talk on that a little bit later on. And not that stuff bores me. You guys love that stuff. That's why I'm here. So I'll give you like a slide, maybe one or two slides on interactions. But for the most part, we're going to leave that to the pharmacy people. And considering I'm a physician, I usually just say speak to your pharmacist. And I'm kidding. I don't talk to your pharmacist. All right. Just take the damn medication. No. Don't do that either. Okay, so here's the case. I like to do case-based learning. I did go to McMaster, and that's how we learn. Can you guys hear me like this? So I don't have to be like, ugh. Okay, that's okay. So we have a 55-year-old female. Look, I got this press the button thing. She has rheumatoid arthritis, fibromyalgia. She presents frustrated after failing biological injections and the side effects of her other medications. What I'll tell you is the average patient coming to a clinic right now is between 50 and 60 years old, and they are usually female, suffering from chronic pain. That is the average age. So we're at around 54 to 55. This is technically a real patient. Medications they're on, hydromorphone. I'm not going to go through all the dosing of it, but they're on hydromorphone, both long and short acting, and gabapentin, as well as lorazepam for sleep. This is like a classic concoction. Pharmacists here, you see this all the time. Yes, raise your hand. Maybe, yes. We see this kind of, and then they're on like 3 antidepressants. We see that, all this stuff, right? You know, it's so interesting about cannabis. Here we go. I haven't even gotten past the first slide. I'm telling you a story. This is why they take an hour and a half. I already forgot my train of thought. I'm going to move on. Forget it. Oh, right. I remember it. I'm going to go back to it. Okay, so I had this a doctor, Dr. Matthew Cooper. He is a pain doc in the Hamilton region. He does level 2 pain. Really, really awesome guy. He came on the podcast, and he said, you know, the paradigm shift for healthcare practitioners is that we're so used to, in traditional Western medicine, having 9 medications to treat 1 disease. But cannabis is backwards. We have 1 medication that treats 9 diseases. And so that is one of the major paradigm shifts and one of those confirmation biases that I was talking about earlier. That's one of those things that we have to start, opening our minds to and taking that little veil off so that we can see the evidence where it may be. So anyway, they're on a whole bunch of medications. Problem is, she finds herself seeking early medications. So she comes to you and she says, is cannabis a viable alternative, either as an adjunct or on its own, in an effort to decrease the dangers of polypharmacy, narcotic use, and help me for whatever ailments I have. So in order for us to understand that, we have to understand the science behind cannabis. We can't just say yes or no. That's how we're governed. We're governed by the science. So we have to understand what is the endocannabinoid system, what is the exogenous cannabinoids, and what are the side effects. So, understanding cannabinoids. The first thing we got to understand is what is the endocannabinoid system and what are the exogenous cannabinoids and how do they interact with each other. So the endocannabinoid system, if you can't hear me, I'm done standing in front of that thing. Can you all hear me okay? Yeah. Beautiful. So, oh man, I keep pressing the wrong button. At least I'm not pressing the X. The endocannabinoid system. This is the cannabis, literally the cannabis, that exists within inside of our body. we have not just the cannabinoids, not just the ligands, but also, which are molecules, fatty molecules, of course. So we don't just have the molecules, we also have their receptors. So there's two main identified endocannabinoids, of course, cell-specific generation, and they are in response to stimuli. I'll show you how they work. They work like a negative feedback loop, not like our normal neurotransmitter that's released from the presynapse through the synapse and then into the postsynaptic cleft. It doesn't really work that way. Cannabis works a little bit different. The endocannabinoids work through a negative feedback, and I'll explain that in a few moments. So the two that we have, the first one is called anandamide, and the second we have, and we already spoke about that. What does that mean? We all know it now. The bliss molecule, exactly. So that's the bliss molecule, and the other one is called 2-AG. And they're critical for homeostasis, and we'll talk about that in a little bit. But they also need places to bind, or they need places to act on. And so they act on both with two receptors, and then also one transient receptor protein. So the first one is the CB1 receptor. That's located mainly in the CNS, peripheral nervous system, and also in your gut. Then we also have the CB2 receptor, and that's concentrated mostly in the immune system, less so in the peripheral nervous system, but there as well as in the central nervous system. Now, when we talk about CB1, the action that happens on CB1, whenever we talk about feeling high, whenever we talk about the side effects, the significant negative side, oh, that's so much better, honestly. We're going to mic up. Give me a sec. Please hold for these commercial breaks. Brought to you by NAC and your friends at MedRelief and Organogram and Peace Naturals. Okay, sorry. Yeah, I had a whole conversation with myself there. We good? Is that better? Is it on? Yeah. Can you guys hear me okay? Did that do anything? Yeah. Love it. Now I can walk around and I can talk. I feel so free. Okay. All right. So, CB1 receptor. Whenever we talk, I'm coming down. Whenever we talk about the side effects, what? Oh, are we shooting a video? Okay. So what should I do? Oh man. Get in the corner, Ira. Okay. But how big is that frame? Not that big. Okay, I'll stand here. So whenever we talk about the CB1 receptor, that is the receptor that's responsible for that feeling of highness. That's the one when we talk about THC, its action, whether it exerts it directly or indirectly, and we can have that discussion, and it can go on forever, it exerts that effort on that CB1 receptor. It's that CB1 receptor that's responsible for feeling high. Most of the side effects that we get related to cannabis is from that CB1 receptor. But then we also have this CB2 receptor, mostly located in the immune system. The one that's also responsible for the anti-inflammatory effect of cannabinoids and the antispasmodic effect of cannabinoids. Sometimes responsible also for the anti-cancer effect. When things, for example, you have CB2 receptors located on cytokines and interleukin, and when those receptors are stimulated, either mostly to inhibit an action, it can actually cause apoptosis of those receptors. So these two exert their force on the CB1 receptor and the CB2 receptor within our body. But how does it actually work? So normally when we talk about the synaptic cleft, the synapse, postsynaptic cleft, when we're talking about, or the postsynaptic neuron, when we're talking about normal neurotransmitters, we're talking about a top-down approach, right? So the presynaptic cleft or the presynaptic membrane, neuron, call it what you will, it usually has you have a stimuli, a neurotransmitter is released from that location, passes the synapse, and then it goes on to affect the end organ that it's supposed to affect. Cannabinoids work a little bit different. It works like a negative feedback loop. Now, what do I mean by that? I'm going to use seizure as an example because I can wave my hand. Because this is your brain on seizure. This is your brain on crack. And there's an egg, and it might be cannabis. I mean, this is the kind of stuff we're told, right? Cannabis, heroin, death. Like, we hear these things, right? Remember, we talked about the history? Anyways, that's a total side. Okay, so this is your brain having a seizure. The part of your brain that's having a seizure will spontaneously produce an endocannabinoid. Usually anandamide in this situation, could be 2-AG, but anyways, either one of them, it'll spontaneously produce. This is your brain having a seizure. This part of your brain, which is literally like down here, spontaneously produces the endogenous cannabinoid. And it is in charge of retrograde signaling of the presynaptic cleft into the CB1 receptor. So it's going to bind, and we're talking about seizures, so it's the CB1 receptor we're talking about now. So we have we're having our seizure, produces spontaneously that endocannabinoid, retrograde, goes back to the presynaptic cleft. It'll bind to its CB1 receptor, or it directly or indirectly. In this case, it could be directly. And that will cause the release of whatever inhibitory neurotransmitter needs to be released in order to stop that seizure from happening. So in that effect, it's a negative feedback loop, right? Same as the renin-angiotensin thing. Remember, we learned that back in school. So the blood pressure thing, your kidney shut, the blood pressure, remember all that kind of stuff? The same idea exists when we're talking about cannabis, when we're talking about the endocannabinoid system and the endogenous cannabinoids, the inside cannabinoids. So 2-AG and anandamide, the retrograde signalers. So they're not produced in the presynapse, they're produced at the end organ based on an insult or whatever it is that's trying to be, you're trying to inhibit or increase. In some cases, I'm using inhibit because seizure we want to stop. It's going to produce it over on this side, pass it back up here. Up here, it's going to bind to that CB receptor. It's going to exert its force in whichever way it does that on the CB1 receptor. And then it's going to cause the release of a neurotransmitter that's going to stop our seizure. Make sense? Good. So what do the endocannabinoids do? Interesting. How many people learned about the endocannabinoid system when they were in school? Pharmacists? How many pharmacists do we have here? Doctors? Other healthcare practitioners? Anything of any sort? How many of you learned anything about the endocannabinoid system? Yeah, we're all in the same boat. There's zero. I asked the question just because, it's an effect. Oh, look, no one put their hand up. But in the meantime, the endocannabinoid system is a master regulator of all of our bodily functions. It's one of the most abundant systems that we have in our body, but we learn nothing about it in school. Got to ask ourselves again, why did that happen? I honestly don't have a good answer for it, especially from a medical perspective, but I think maybe, I don't know. I'm not even going to take a guess. But in the meantime, it's important for the regulation of metabolism, energy regulation, brain development, immune homeostasis, memory, digestion, learning, stress. I can keep on going for all these things that it's actually really good for. But in here is where one of our issues lies when it comes to prescribing and it comes to using cannabis. If it affects every system within our body, and we have receptors from our head to our toe, and I'm telling somebody to take an exogenous, outside our body, cannabinoid, I can't tell it where to go, right? So it's non-specific. It's not a very specific modulator of whatever we're trying to modulate. So it may affect your head and it may affect your toe all at the same time. Now, most of our drugs do that, but some are quite specific to cell, or for cell signaling. Unfortunately, cannabinoids aren't, and in here lie some of the side effects that we're going to talk about eventually. Anybody watch Friends? Identify. No? Anyway. All right. Hey, somebody watches Friends. Okay. So then we have the exogenous cannabinoids. I got to stand here for the picture. Hi. So the exogenous cannabinoids. We already spoke. Oh, by the way, now we'll look at the difference in actually how, I wish I put like covered up sativa indica and ruderalis. So remember I was telling you about the locations of sativa, and basically when we talk about sativas and indicas, we're talking about geographical locations. And if you have a plant that's a sativa, it's an equatorial plant. So you have these long, tall leaves. They're really thin, and they're actually slightly curved on the inside. So they go like this. Why? Because you need the water to come down and water the rest of the plant and clear it from all the bacteria. That's how it developed. So that's what a leaf would look like. Whereas this indica sort of looks like, stocky, small, protect from the cold like me, right? So basically, that's what an indica looks like. But then you have this ruderalis. We see this often. Hybrids tend to look like that as well. Okay, so we have different species. We already spoke about that. The two most common ones are Cannabis sativa and Cannabis sativa L, which is the hemp. But then we also have the Cannabis indica. I'm not going to go back through that. These are the exogenous cannabinoid elements. So what is the exogenous cannabinoid system? Now, you may say that it's not a system. From our perspective, you're right. If you're a botanist, it's a system. If you're a healthcare practitioner, they're endocannabinoids. So the endocannabinoids, what are they? They're phytocannabinoids, the plant-based cannabinoids. There are over 100 of them. I think we're up to like 160, somewhere around there, 160 cannabinoids. But how can we keep them all in mind? Well, we can't exactly do that. So there are only a few that we actually study pretty hard. The most commonly studied ones are THC, delta-9 tetrahydrocannabinol. We've all heard of THC. It's the CB1 agonist, and it's a weak CB2 agonist as well. So remember when I talked about CB1, and when I talk about CB1, we're talking about the receptors inside our bodies. Remember I said we've got the endogenous cannabinoids. Which endocannabinoids do we have? We have two of them. One is the Bliss molecule known as anandamide, and the other one's called 2-AG. They have two receptors. There's really three, which is a transient one, but two major receptors. What are those two major receptors? CB1, CB2. The one responsible for most of the side effects is CB1. Awesome. THC is the one that exerts most of its force on the CB1 receptor. Now, it's not direct. It can be indirect. There are some cases in when it actually acts directly, but either way, it exerts most of its force on the CB1 receptor. It also does some stuff to the CB2 receptor. We'll talk about it a little bit later. And then we have the second one. And the second one we talk about, and which is really boutiquey, and everybody all of a sudden is talking about it. We've been talking about it for 2 decades. But in the last year, as soon as it gets out into the market, somehow everyone's like, oh, CBD, it's not going to get you high. You're right, it doesn't. It doesn't have the psychoactive effects because it doesn't interact. Well, it does, but it modulates the CB1 receptor only as an antagonist, but it actually modulates the CB2 receptor more than it does the CB1 receptor. Now, is it the CB2 receptor modulation or the inverse agonist of a CB2 receptor that causes its effects? Maybe yes, maybe no. It acts in ways that aren't even on the CB receptors at all. And we're still learning about those things today. What we do know about CBD is that when so I remember THC binds or interacts with the CB1 receptor, right? It exerts most of its force and causes an action. It agonizes the CB1 receptor in some way. CBD, on the other hand, sort of works like competitive inhibitor of the CB1 receptor. So the more, if you have THC and it's exerting its force on that CB1 receptor, CBD can come along, kick it out of its way, and exert its force on the CB1 receptor, stopping the negative effects that it has at that CB1 receptor site. So really kind of cool, right? So how does it do that? So, I mean, it does it through modulation of the receptors, but that of the CB1 receptor. But you have a plant that has its own built-in safety mechanism. The CB1 receptor agonist, when you agonize the CB1 receptor, you're causing that action. That's that psychoactive effect that you're going to get, one of the effects. But when you add CBD to it, it's going to modulate that effect. That's why it's always important to have a little bit of CBD with your THC, because you can decrease that feeling that you get or the side effects that you're going to get related to the CB1 receptor. Make sense? Makes sense. All right, so what kind of cannabinoids do we have on the market? So we just spoke about the exogenous cannabinoids and how they work. We have over 160 of them. The two major ones that we talk about are THC and CBD. Hey, listen, there are metabolites, for example, THCV, that's excellent for weight loss. Problem is it vaporizes off really quick and it's hard to metabolize, it's hard to actually find. Ingested cannabis, this is totally a side note, ingested cannabis tends to produce more of it than vaporized cannabis because it's a metabolite that, after first pass metabolism, when we talk about dosing, we'll talk about all that stuff, produces more THCV than you get through vaporization. But, that's just another example of one of the other metabolites. But then you have things like CBC, CBG, CBN. There are so many different cannabinoids. They're just not to the same extent. One, they're not studied to the same extent, but also they're not as abundant as these cannabinoids are. So what do we have on the market currently? I'll start off with the bottom one. We've all heard of it, Sativex, right? Nabiximols. It's that everybody heard of it? Let's just raise some hands. It's like we don't want to be bored. I should jumping jacks. Oh, I'll break that. Sativex, you've heard of it, heard of it, heard of it. Any of you guys heard of it? Nabiximols, it's the same thing. So it's a blend. It's actually whole plant cannabis, herbal cannabis extract, put into a 25 milliliter bottle. It has 2.7 milligrams of THC and 2.5 milligrams of CBD. Not bad. I actually use it in the elderly population as well. It's a buccal, I don't know however you pronounce the word, spray. And you can spray, it says spray between maximum of 12 sprays per day. Little 25 milliliter bottle, or actuations. If you don't want to say spray, we're being technical. Let's call them actuations. So you can go between 2 and 12 actuations. It's interesting. You can go on Health Canada's website and look at how they conducted the studies on nabiximols. Some of the study subjects had to spray up to 40 times per day for it to be effective. I only know that because one of the studies that I'm currently conducting were sort of mimicking the way that these studies were conducted in order to get through the DIN process and the whole thing. But it's real. So you have to spray a lot of times. Really smart producers of this. It's a little 25 ml bottle. It's about that big. Each actuation has like 200 mics, something like that. I can't remember, 200 to 400. You guys may know better than me. Spray up to 12 times per day. How long do you think it's going to take to run out of that bottle? A week, max. And some people have to spray more than 12 times per day. And it's a super expensive venture. You're looking at $1,000 a month sometimes if you're properly using it. So it's really expensive. There are some insurance companies that do cover the cost of it as well. Let's move to Nabilone. And we don't have it on formulary in hospital, but you guys have access to it. Moving on to Nabilone. Nabilone we've all heard of Nabilone, Sesamet, right? The little blue and white sort of pill. Interesting, somehow it has a DIN number and it's like healthcare practitioners love it. And they all talk about THC being the biggest problem with cannabis. I don't want to get high. What do you think Nabilone is? Synthetic THC. Like that's literally all it is. It's synthetic THC. This, at least like Sativex is a herbal whole plant extract. I'm not getting into the entourage. We can talk about that if you want in question time. But when we talk about Nabilone and we talk about, here often, well, I don't want to get high. I don't want to deal with THC. And I hear these ridiculous comments by the CMA that shouldn't be putting out even, they sell insurance. I have no idea why they even put out these ridiculous policies. But anyway, these guys come, oh, we don't want to talk about THC. But in the meantime, oh yeah, we have Nabilone, and it has a DIN number, and you should just prescribe that. So that's synthetic THC. Doesn't make a lot of sense, but at the same time, it's really good for specific populations. It's good for the elderly population. It's good in hospital. somewhere that they don't have access to other cannabis. We have it on formulary in our hospital. I use it all the time in the emergency department. Patients come in and complaining of pain. I'm like the anti-opioid use. Not that I don't think there's a place for opioids. There certainly is a place for opioids in acute pain. We know that, and I think we have to be clear about that message as well, right? We can't tell people to don't be afraid of them, don't use them, you don't need them for more than 2 to 3 days. But there is a place. There's no real role for cannabis currently in acute pain syndromes, right? But patients that come in to emerge with chronic pain, I failed everything, I've got sciatic pain, I got this pain, I got that pain. Doc, I need all the drugs. I can't get into my family doctor because they don't want to see me because they're on some FHO or full FIG and they see 10 patients a day. You know how it is, family docs. So they go to a walking clinic, then they get negated and you get yelled at. It's a whole to-do. Anyway, in the meantime, they come to emerge complaining of, not that I'm bitter, they come to the emerge complaining of pain, or, interestingly enough, I use it for behavior modification in the elderly demented patient. And it works amazing. I'm just actually about to start an RCT on that. A clinical trial, like a randomized control trial on it, but I use it all the time instead of things like Haldol. You know, if they can't swallow, then clearly I got to go to the Ativan Haldol and shoot them with a little bit of Benadryl in there to decrease the extrapyramidal side effects that they're going to get from the Haldol. I put it all in a 10 cc syringe and it works great. But if I don't want all the side effect problems and they can swallow, I give them a milligram of Nabilone, and they're like, happy as can be. Now, of course, it's not all of them. But again, synthetic THC. One strain, it's not even one strain, it's synthetic. It's super expensive. It's been on now I have this on back order. It was on back order for the longest time. I don't know if any of you know if it's available again. It is, yeah, I'm pretty sure it is as well. But again, I can take a handful of these pills and stuff them in my mouth. The toxicity, we don't have a level of toxicity for it, but you can assume that it's a lot easier to take a handful of pills than it is to eat 300 grams of cannabis in one go. You'll end up with a bezoar, so you may not be pooping for a while, but you're definitely not going to overdose. So we have Nabilone and we have Sativex. Those are the two synthetics. This is a herbal in a spray. Both of those have DIN numbers. Most of these studies were actually done in Britain, I think. And then we have medical cannabis. That's the herbal cannabis that we know of. It comes in two forms. We'll talk about that when we talk about dosing. The good news about it is I have thousands of strains to choose from. But that also makes it one of the most difficult problems, right? How do I know which strain to choose? And this is a question you guys are going to have. How do I know what's best for my patient? How do I know X? How do I know Y? You know, like, is this one going to work for pain? Where's the evidence for all this? You know, at the end of the day, the most important thing we can remember as healthcare practitioners is to do no harm. And then do everything else you can for your patients and for your clients. And that's really the underlying key of everything we're doing. So we know the harm factor, and I'll talk about that when it comes to cannabis, versus 75% of patients who use it are using it for pain, right, in some sort. Their alternatives kill you. And I'll show you a slide on that. Your opioids, your benzos. Benzos, by the way, I'm sure you all know this, are worse than it's almost worse than alcohol, and it's almost worse than opioids. Try taking somebody off of a benzo, it's impossible. And they die, right? So there's death associated with all those other things. Not to say that that cannabis is the answer for everybody. There are significant side effects. But we know the lack of harm, so it's worth a shot. That being said, there are so many strains, so how do you know? So when we talk about dosing, we're going to talk about THC and CBD and different ratios and just a guideline of starting that takes you through start low, go slow, and then gives you actual dosing numbers. That's how we're going to talk about it. We're going to talk about it in the same way that we talk about any other medication. There are some differences because it's difficult to, how do you teach somebody to vaporize? It's not like, here, go home, take 2 of your, metoprolol, and I'll see you, and then take, 1 in the morning, 1 at night, BID or whatever, and then I'll see you in 2 weeks, and we'll see how you're doing. I'll see you in 3 months. This is like, well, here, load the flour into this thing, or take this oil, make sure the dropper, works. But it's honestly, if we're looking at oil, compare it to like tempera, because it's the same idea of dosing. You're using a little dropper, same idea. You teach them how to do it for kids. You can teach an adult how to do it for cannabis oil. And then when we talk about flower, it becomes a little more complicated, but still, once they learn how to load the thing and press the on switch, that's it. Makes it pretty simple. So, let's get into some of the side effects of cannabis. I like this, I don't know how Jimmy there incarnates because I don't really like Jimmy Carter, so I just got to separate his name. But I like this one quote. Penalties against the possession of a drug should not be more damaging to the individual than the use of the drug itself, and where they are, they should be changed. I think that makes a lot of sense. I think that was one of the major rationales around cannabis legalization. Not necessarily the medicine of cannabis, it's been around forever. But around legalization, we know that it doesn't work. We've got jails that are filled with people causing more problems on taxpayers than actually having people being productive to society. We currently have an entire industry of productive people that are looking to be productive or continue to be productive, and the governments are starting to come around to that idea, doing what they should be doing and taking their end, which is taxing to use on whatever, and letting people be productive versus sticking them in jail and taking away their voice. I think we spoke about that already. So what are some of the evidence-based side effects? I really like this slide. By the way, I'm going to put in, here's the ski slide. You don't see it, but that's me skiing in the Arctic and just below an avalanche, which is right above me, if you can picture it. We're like skiing off to this 45-degree angle. You're looking at about 2.5 meters high and 250 meters long. That's the picture you would have seen here. Thank you, Pram. I love it. Okay, so moving on to here. I lived on a boat for 8 days, like on the northwestern, I don't know, I'm terrible with directions. Anyway, off the coast of Iceland, in the fjords, close to the Arctic Circle, and I did this ski trip there. That's sort of what happened, and I would have had those photos for you. Pram. Okay. Next time. All right, so I really like this slide. This was done by Gable. Oh, right. This was done by Gable in 2006. And it lists most drugs of abuse and most medications you can think of. So over here is over on this side, you're looking at your lower risk drugs, and on this side, you're looking at your highest risk drugs. And then you're also looking at addiction rates as you go up. There is addiction. We can talk about addiction when we talk about cannabis and cannabis use disorder, which is how it's classed in the DSM-5. We could talk about that, and please feel free to ask questions about it if I don't remember to go down that road. But so let's look at, what did I say? 75% of patients and anybody else that that gets asked the questions regarding cannabis, would you say about 75% of your patients or clients are looking at cannabis for pain purposes of some sort, whether it's arthritis, whether it's fibro, whether it's, whatever, headaches, whatever, GI, Crohn's disease pain, those types of things. You're looking at about 75% are pain related. So down on this end, we have cannabis, and we're looking at, a side effect profile that's 1 in hundreds of thousands, versus let's go to morphine and all of its side effects, which you're looking at 1 in 10. To be honest, anybody over the age of 65, like nearly 100% of patients using opioids over the age of 65 are going to have a significant side effect. Doesn't mean it's going to be like a mortality outcome, but will have a severe side effect to it. 1 in 8 people who die under the age of 45 die from opioids. Lately, I'm telling you, I'm seeing 1 in 3. That's what we're seeing currently, in mortality rounds. So it's pretty significant. And then when we look at, its other alternatives, so we're looking at morphine, we compare it to this. Oh, the addiction rate, you're also looking at about a 23% addiction rate to morphine. You're looking at about a 4 to 6% addiction rate. Based on the 2015 census, you're looking at about a 4 to 6% addiction rate to cannabinoids. They do exist, it just presents a little differently. But then let's look at things like benzodiazepines. Well, you're looking at the same sort of location. I'm really looking at these two things. Yeah, heroin is up there, of course, and we still, how many of you dispense heroin still in the last couple days of life? I guess nobody in here does, but we still do. We still give it in the hospital. Now with the MAID program, if you want to get MAID, we just use propofol for the most part. But medical assistance in dying, sorry, that's the MAID program. But you can still use heroin in the last few days of life, of course. But then let's look at things like alcohol, right? So even if we compare cannabis, it's still marijuana, we're 2006, so still using the word marijuana, compared to alcohol, we're looking at as an argument for legalization. I mean, it's spinning right in front of us. Even caffeine is on a higher side effect profile rate. Okay, so this only goes to 2012. I should have had 2015 put in here because we're talking about what is the rate or the incidence of cannabis use across our nation. This comes from Cannabis, and although we have an updated one, 2015, how many of you kind of knew that? I did not know that it was mandatory to fill out this home census. You know what happens if you don't fill out this census? They knock on your door, you go to jail. There's like jail time, so I'm like, thanks, I already have enough problems. I didn't know that. They send me this letter, I'm like, I don't really read my mail. How many people read their mail every day? Like, do you read your mail every day? No, once a month, maybe? Like, yeah, and especially if it's not delivered to your house. If it has to go to, got to go to the community mailbox thing, you're looking once a month, maybe. Anyways, so I missed this thing. They knock on the door. You got to fill it out. You go to jail for 2 years. I'm not. What do you mean? And of course, it's the long form. I get the one that's not 5 minutes. It's like 45 minutes. Anyway, okay, I'm over that. Oh, okay. So what's the rate of cannabis use? You're looking at every general population lifetime use within Canada. You're looking at about 42%. We're up to about 43% right now, but anywhere between 40 and 45%. That's with the average population. That hasn't changed since 2004. Rates of cannabis use aren't skyrocketing. They're not going up. They're not doing the things that we think they are. What we're doing is getting more coverage for them. We're noticing them a lot more. Why? Because it's in the media. We're seeing doctors talk about it. We're seeing pharmacists talk about it. We're seeing a whole industry that's literally exploded in the last 5 years, right? So the birth of a new industry is helping us, or it's helping us in some ways, but at the same time, people think that now the cannabis use must be huge. It's not changing all that much. Where I can tell you that it's changing quite a bit is what I'm seeing in the emergency department. And this comes from a lack of education. I think we have a really inconsistent message currently being thrown out there by our government. On one hand, and I put this out in a press release a couple weeks ago, on one hand they're saying, hey, it's legal, use it. It's legal, let's go, it's going everywhere. Don't use it, crack, here's your brain on crack, here's cannabis, use it, brain on crack. So nobody really knows. It's a really confusing message. I'm doing that because that's me flipping eggs. Remember those commercials? Anyways, I had the whole picture in my head, and it sounded really good. I hope you can picture what I was doing. Okay. So, by the way, I got the whole cannabis heroin death. I always have to give credit to people who said that. It actually came from a guy when I was in Iceland, or in that area, the captain. That's basically how their government looks at it still. You start cannabis, you move to heroin, you're going to die. That's the only way. But that, again, remember we were talking about that confirmation bias? That's the confirmation bias. But that's how people literally look at cannabis, like you're going to use it, and you're going to be lazy, and you're not going to be productive, and you're going to move to heroin, and then you're going to die. You know how many people I see as a coroner dying from cannabis use? None. Okay, 0 of them. Doesn't mean there's not side effects, of course, and it's definitely not a gateway drug. Keeping it illegal is a gateway drug. Keeping it illegal is what makes it a problem. Because where do you have to go to get it? You got to go to a crack house. You got to go next door, and what are they selling with your cannabis, right? That's the biggest problem that we have today. It's not the cannabis that's causing them to use hardline drugs. It's keeping it illegal that's causing us to use hardline drugs, because you're in that environment all the time to get your stuff. And we call it selection bias when they did these studies. This is totally an aside. How much time do I have? I got time. So here's a story. All right. Because I probably won't get to myths and all that stuff in here. So, one of the myths is that cannabis is a gateway drug. How many of you have heard this? Yeah. Cannabis is going to lead you to heroin. Cannabis is going to lead you to death. And you're all going to be lazy and sitting on your couches. Again, this is where you should read that article by Diane Riley, 1998, for the Honorable Pierre Nolan, Parliament of Canada's website. You can find it. If you want to read 120 pages, it's super interesting. Really small font, maybe 10 or 11. But it was excellent. And she goes through all those things. So let's talk about cannabis as a gateway drug just for a quick second. When you do a study and you want to look at cannabis users, or you want to look at are people who use cannabis also using hardline drugs? How do you think you should set that study up? The way you set a study up is so important to get the answer that you're looking for, or to ask, or to answer the question that you're trying to study, right? So you have two ways to set that study up. You can either do it appropriately and look at cannabis users who are also using hardline drugs, or you can look at hardline drug users who are also using cannabis. Do you see the difference? Right? So what percentage of hardline drug users do you think use cannabis? No, 100. All of them. Hardline drug users, crack, cocaine, heroin, who are also using cannabis. Most of them. Right? How many cannabis users are also using hardline drugs? 3%? 2%? Very, very small percentage. Now, if you're conducting a study, and most of these studies were conducted that way, and you look at hardline drug users and say, well, look, hardline drug you got 100% of hardline drug users using cannabis. Cannabis is a gateway drug. That's what we call selection bias. The population you're studying is the wrong population. You need to be studying cannabis users, not hardline drug users. Because when you look at the cannabis users, they're not using hardline drugs. It's the hardline drug users that are. Actually, and I told you this earlier, wherever cannabis laws are more lax, hardline drug use goes like pretty much like down to 2% from an average of 4 to 6% in any given society's population. So cannabis is not a gateway drug. I'm also going to quickly, let's briefly touch on the cannabis as a lazy person's drug. You're going to be unproductive to society. We've seen this. And the truth is, you can't stop stupid. You want to abuse a drug, you're going to abuse a drug. You want to sit in your chair. Obesity kills more than anybody. You want to sit in your chair all day, you're addicted to your chair, and you're addicted to popcorn. Well, popcorn's okay. I like popcorn. And I like chips. So like other bad stuff, that isn't the stuff that I like. But sitting down in your chair, you want to be addicted to those things? You're going to be addicted to those things. You can't stop, and I mean, you can't stop stupid. So you're going to find people. Of course, there are people that have an addiction to cannabis. But and so we see, I get physicians that say, well, I have a 16-year-old kid that sits all day on the couch. He's dropped out of high school. He wants nothing to do. I'm like, oh, it sounds like me. I was all those things. But I wasn't, and never inhaled. No. Okay. So, geez. Okay. I don't even remember where I was. Yeah. Okay. So the person sitting on the couch. So they've done those studies, and this is where you should look at the Diane Riley thing again. Those who use cannabis compared to those who do not use cannabis in the first-year post-university population have a higher income. So those who use cannabis earn more money than those who weren't using cannabis. Okay? These are just facts. You can go look these things up. And I told you where to look it up. If you don't trust me, you don't have to trust me. You can, but you don't have to. I would suggest always going to the source. That's probably the most important thing we can do. So, is cannabis a gateway drug? No. Does cannabis make you lazy? If you want to be lazy, you're going to be lazy. It doesn't matter what you're doing. You want to abuse something, you're going to abuse it. But do you have to be that way? Absolutely not. Okay, let's move on. That's a long rant. Jeez. Let's go back to side effect profile. When we talk about side effect profile, we're mostly talking about THC, and we're mostly talking about its exertion, its force that it's exerted on the CB1 receptor. Okay? So, cardiovascular. These are the material risks that you need to discuss with your patients. There are absolute contraindications to the use of cannabis, and I'll talk about those as I go. But these are the major ones that we usually talk about. Tachycardia. Tachycardia is really important. Why? Because if you have an elderly patient, and that patient has paroxysmal atrial fibrillation, or a tachydysrhythmia, which basically means if that patient of yours or your client has a problem with their heart where they have a fast heart rate, they may not always be in that fast heart rate, and they're not treated for it. Cannabis, THC, can potentially throw them into that rhythm for two reasons. The first one is more of the like esoteric one, and that's because cannabis, THC, has the potential to get you high. If you're a naive user and you haven't used cannabis before, you may not be prepared for that experience if you use too much too quickly. The people that are presenting to the emergency departments, oh, see, I knew I forgot something. The ones who are what we call greening out, it's because they've eaten 200 milligrams of THC because it was in a tiny little donut this size that looked, shit, how I gotta eat that thing. It looks awesome. How can you just eat one tiny bite? You can't. Like, you eat a Timbit, you eat a Timbit. Have any of you eaten a half a Timbit? No, like that's impossible. You can't eat half a Timbit. But you go to a dispensary and you're gonna get a Timbit-sized, donut that has 200 milligrams of THC in it. So, oh, sorry, just take one little bite every 6 hours. Okay, this is a waste of whatever, But these people are showing up to the emergency department greening out. Their heart rate's 130, 150. Why? Because they're scared. That paranoia that you can get from a quick dose of THC that's too high that you're not used to can cause that to happen. So that's the indirect method. But then remember how I said, you've got cannabinoid receptors on most of your systems. I've left out one specific system, and that's your endothelium. You have CB1 receptors on endothelial cells located in the myocardium. So you're going to get a direct effect, a direct response, a direct tachycardia related to THC modulating the effect of the CB1 receptor on the myocardium directly. Okay? So that's the second method. Now, let's move to the second thing here, postural hypotension. This is actually a real, I think this is one of the more significant side effects, even more than tachycardia. I say that tachycardia isn't even that, big of a deal because I've never seen, I've treated maybe 10,000 patients, maybe more. But also, when I started, it wasn't me. I didn't have the answers. So I went to every specialist I knew, from cardiology to respirology to nephrology to neurosurgery, everybody you can think. I bombarded them every time I had a patient because nobody in the country was doing it, and I didn't have I'm not a cardiologist. I'm an emerge doc with a subspecialty in sports medicine and a focus in pain. That's what I do. Yeah, so I have some general knowledge about cardiology, but I'm not a cardiologist. So what I did when I first started for the first 2 years, the most important thing you can do is find mentors. There was nobody in cannabis, so I had nobody. But what I did have was specialists who can answer specific questions. So I went to every single one I knew, and I started asking them. I went all the way to Israel to ask these guys questions. Have you ever seen it? I would go to cardiologists. Shoot, sometimes I'd see them walking on the street and be like, what are you talking about? Have you ever seen anybody that's had a tachycardia related to cannabis use? Or I have this patient who's post-MI or post-cabbage. They're interested in starting cannabis because they have chronic pain. What is the problem? I have a patient on dialysis who has one kidney. Can I use cannabis? These are the things that I would literally ask every neurologist, every specialist that I knew. So that's how we came up with these sort of, these side effects. It wasn't just on rat models. So there was a lot of that happened for the first, I'd say, 5 years that I was doing it. I still, when it comes to pediatric population, I was still, or even neuropsychiatry, I will only do those things in conjunction with a pediatrician or a neuropsychiatrist who's able to work as a team in the circle of care for that patient, because we can't work alone. Working alone doesn't work. We have to work as part of a team. So why I say tachycardia is low is because nobody's ever seen it and they said don't worry about it. Postural hypotension I see all the time. Postural hypotension can happen both because of THC and CBD. Both of them can cause them for different reasons. We're not going to go into all those details, but we need to know is that both of them can cause that. Where is the problem most significant? CBD tends to be the bigger culprit in the factor, but either way, postural hypotension is important because if you have an elderly patient who's already got low blood pressure or is already at risk of falling, this is something that you need to really take into consideration. So it's something you need to counsel on. Smoking angina. I mean, nobody should be smoking. Like it's 2018. You know, it reminds me of another little story. Did you guys see that meme where you walk into a restaurant, you ask them if they have Wi-Fi, and they say no, you know, and your response should be, well, I'm going to smoke and pay 50 cents for my coffee, right? It's 2018. We don't need to be smoking cannabis anymore. Smoking cannabis, combusting, incomplete combustion. The problem isn't smoking. The problem is incomplete combustion. Incomplete combustion from a lighter and fire is not good for you. Causes cancer. There's overwhelming evidence that it causes, whether it's tobacco or it's cannabis. Why would you take such an amazing plant that's so good for you and literally just burn it? It doesn't make any sense. You know, it's like you telling your patients to go home, take your Percocet and freebase it. Like, it's just like let's put it in a spoon. Crush your Percocet, put it in a spoon, light it up, put it in an IV and put it in your arm. Why would you? Do any of you do that? Is that how you tell people to use their narcotics and their medicines? No. So why would you tell them to go home and smoke something? Combust it. We have better methods like vaporization. And when we talk about, do I sound really Canadian when I say about? Anyway, okay, good. When we talk about dosing of cannabis and methods of use, we'll talk about vaporization as well, and I'm sure you guys were going to be taken through how to use a vaporizer. But it decreases like 98% of the toxins that are found. Not only that, you save 50% of your money because the amount of the bioavailability of vaporization is nearly 50%, where the bioavailability of smoking a joint is 10 to 15%. So you're losing literally, remember the Cheech and Chong up in smoke, that's where my money goes? You can leave out sometimes up my nose part, but yes, that's, if nobody knows, anyway, okay, I thought that was funny. You know, you guys are we tired? A little bit, hungry, need some wine, maybe wine will help. We're getting there right after this. Okay, so, we're on smoker's angina. Bottom line is, you don't need to tell somebody to smoke. That's from combustion. Let's move on to neuro. Euphoria. Okay. So a lot of our patients, you know, the elderly patients, most certain, or those who have jobs where they need to, you know, drive and stuff like that, they don't want to feel euphoric. I listed here as a contra or as a relative, negative side effect of cannabis. Have any of you read the National Pain Guidelines in Canada? Yeah, the National Pain Guidelines, when talking about opioids, talk about indications, benefits, and risks. What is the first indication for using an opioid? I'll give you a hint. It's right here. Euphoria. That's the number one benefit of using an opioid, listed in the National Pain Guideline. What is the number one, first, not number one, I'll say first, at least from in the 2011 edition. I think they've been updated, but they still say the same thing. What is the first relative side effect to using a cannabinoid listed? Negative side effect. Euphoria. It seems a little strange, doesn't it? On one hand, when we're talking about opioids, the number one benefit is euphoria, and when we talk about cannabinoids, the number one relative risk factor is euphoria, or negative side effect is euphoria. It's weird. It doesn't make sense. So what does make sense is let's use our knowledge. Let's weigh the risk and weigh the benefit. If somebody wants to feel slightly euphoric, that's okay. That's the number one reason to use an opioid, because it helps with the quality of life. On the flip side of that, if they don't like that feeling, we can always moderate that. How? Add a little CBD. Why? Because CBD modulates or changes as a competitive inhibitor of the CB1 receptor. It'll kick off THC. Not that it's binding, metaphorically speaking. It's going to throw away the THC. So you'll decrease the upregulation. We can go through that whole thing. But let's just look at it as it throws away THC, right? So add a little CBD. And CBD doesn't have those psychoactive effects. That's euphoria. Memory. Short-term memory, it can slightly be affected. If you want to talk about long-term memory, doesn't really affect long-term memory. Actually, in fact, THC is the number one inhibitor of beta aggregation. What is, like, strong inhibitor of beta aggregation? What does beta aggregation cause? Number one cause of Alzheimer's. So, I mean, are we in clinical trials yet? There are people that want to do clinical trials on this stuff. Do I think it could happen in the future? Potentially, we're not there yet. Attention, it can be affected. Psychosis. So this is like the first real, I would say, out of all these things, the absolute contraindication. If you have a history of psychosis or predisposition to psychosis, I think there is a causal link now between psychosis and early onset and early cannabis use, which is why they try to keep it away from the use in adolescence. So stay away from people who have bipolar with psychotic features, people that are not treated, schizophrenic, or have psychosis NOS, or have a first-degree relative who have a history of psychosis as well. Bronchitis. Bronchitis is not, got to stay in that lane. Bronchitis is not from vaporizing. It's not from the cannabis. It's actually an antioxidant. Both THC and CBD and the leaves and everything in them are actually quite good at it being antioxidants. The problem from combustion can cause bronchitis. Pneumothoraces. Certainly you can get a pneumothorax. See it all the time in the emergency department. That's from breath holding. You know, people come in and they're like, you know, people think they only get, doc, I only get high if I'm take this big inhale and I gotta hold my breath, they cough, and then all of a sudden, oh, now I feel really high. Well, you're not high because there's not more diffusion between your alveoli and alveolar respiration. You're not getting much more into your lungs. You know what you're getting is an anoxic brain injury. You hold your breath after combusting cannabis, and by the way, a water bong has probably more toxin. It all gets trapped in the water, and then you inhale the stuff versus it going somewhere else. You're getting all those toxins. That inhalation, that inhaling is causing an anoxic brain injury. That's what's happening. It's not I'm getting higher because of alveolar respiration. The difference between holding your breath for 1 second and holding it for 1.2 seconds isn't very much, or 3 seconds is not very much. There's not much of a difference in the diffusion capacity. So don't hold your breath. Don't in one deep inhale, one exhale. That's fine. It can happen with a vaporizer, but it has nothing to do with the method of use. It has to do with the breath holding. Pulmonary toxicity. How many people have read in the paper cannabis or marijuana? They're not using cannabis for that. Marijuana killed person X. Have we read this? Yeah. So the things that when we talk about herbal cannabis, they're not talking about the same cannabis we're talking about. They're talking about bath salts, K2, spice, salvia. Those are cannabinoids. Those are synthetically produced, except for salvia, which is a natural. They use it in certain, we have to be careful about salvia because it's only been made illegal recently here, but they use it in a lot of different forms of ceremony, and they think it's okay. But it's bred for one purpose. It's bred as a CB1 agonist, but with such affinity for the CB1 receptor that it doesn't let go. Almost like cyanide to cytochrome oxidase. Like, it just doesn't let go. And so you get higher and higher and psychotic, and eventually you go through this whole agitated delirium and then you die. That is very possible. And you can also get pulmonary toxicity, pulmonary hemorrhaging. Those things can happen. Actually, salvia interacts quite heavily with things like Coumadin. So we have to be careful about those. Cannabis hyperemesis syndrome. This one's dear to my heart. We've all heard of this. This is like a new big thing. Everybody kind of loves talking about it now because whenever they talk about side effects, we have to find things to talk about when we talk about cannabis because it doesn't kill people and it's not as cool as talking about opioid deaths, but we want to talk about like all the bad things, so we have to talk about it. This one I've actually published a pretty good trial on. I don't remember, I think it was the Canadian Journal of Emergency Medicine. I can't remember for certain. 2017. Cannabis hyperemesis syndrome is a real thing. And the distribution is bimodal. You could have used cannabis once, or you could have used cannabis like 100 times. And sometimes, in some populations, it's actually really good. THC is an anti-nauseant. There are studies, RCTs, comparing it to things like ondansetron and being as effective as ondansetron in things like post-chemotherapy nausea. Excuse me. That being said, in a certain population, and we don't know the underlying pathophysiology of it yet, it can actually cause cyclical vomiting and cause you to vomit. We don't know why. Patients hate hearing about it, especially the ones that have been using cannabis for a long time. They never want to admit that it's the cannabis. It's something else other than that. But it can happen. You know, I started, because we see it often in the emergency departments. We used to call them all cyclical vomiters. Now, now it's what came first, the chicken or the egg. Were you using cannabis first or were you nauseous first or vomiting first? And so the way I kind of explain it to patients is we don't really know the underlying mechanism of why this happens, but compare it to like an allergy. Unfortunately, it's a plant. Unfortunately, you have like this sort of allergy to a plant. Now, is it accurate? No. Certainly that's not an accurate comparison, but it's an analogy that they can potentially understand that removes the self, the I, it's not me, it's not the cannabis because I have to be defensive over my cannabis, and it takes it away from them, and it's an unfortunate event the same way people have allergies. So when talking to people, that may be a way until we understand the underlying pathophysiology of it. Increases hunger mechanisms. Certainly it increases hunger mechanisms, although people tend to have better glucose control because it influences pancreatic islet cells and regulates blood glucose quite well. So even though you have an increased hunger, unless you're eating, you have to make really good choices. And the reason why it increases hunger, specifically THC, because it increases nososomia. It improves your sense of smell. And we know that your sense of smell is the #1 predictor of hunger. It's located throughout your brain. And we talk about psychosis. So cannabis drug interactions. I'm going to leave all this stuff for Chirag. Oh, you took out my I had this like really cute picture of this sleeping baby that was like sort of sitting there like snoozing when we talk about the oh, that's too bad. Thanks, Pram. I know, but I like that slide. Why is it all? It's not my slide. Anyway, what we need to know is that the Psych 450 system is like definitely responsible for metabolism, both of THC and CBD. Both of them are really important, and and I'm going to let Chirag. You're going to talk about all of that stuff. Yes. Oh, both of you. Okay. So I'm gonna move on from this so that we can, I'll let you guys discuss that. Things that are important, of course, is dilantin levels. We have to worry about that. Clobazam, warfarin, rifampin, because you have a lot of rifampin patients out of hospital. But you never know. Theophylline, we use it all the time. But anyways, you have to worry about these things slightly. Of course, when we're talking about what's that? When we talk about specific additive effects, we have to talk about alcohol. There is a metabolite that's produced. We should stay away from cannabis and alcohol together. Opioids, of course. Opioids are an interesting one because in small doses, cannabinoids and opioids are actually synergistic. Cannabinoids not only, I know I mentioned that they exert their force on the CB1 and CB2 receptor, but they actually also exert force on delta receptors. Now we know we have a whole bunch of delta receptors and mu receptor, But the delta receptor that is not involved with most of the reward mechanism when we talk about addiction is, I don't know, I think it's a delta 3 receptor. I can't remember exactly offhand. We should verify that and look that up. But the good thing about THC is that it spares that one receptor. So that's why one of the reasons why addiction presents slightly different. But we have to be wary of that. Benzodiazepines, of course, it's not that you can't use them together. You just have to make sure that they're appropriately being used. Of course, sympathomimetics, because CBD, for example, does improve wakefulness. You can have the same sort of idea with sympathomimetics, anticholinergics perhaps, and antidepressants we should be careful of. These are all things to take into consideration. So what is neurocognition side effects? There is no actual, and this comes up all the time, what are we going to do for driving now? You know, what are we going to do at the side? Like, what are we going to do for baseline testing or roadside testing? There's actually no standard level that we have now accepted for impairment. The level that we use for alcohol is called standard field sobriety testing. That's actually backwards. FSFT testing. Standard field sobriety testing. That's these 7 things, you know, is touch your nose and do this whole to do. So we know that it actually doesn't have very good sensitivity at the roadside. It's probably about a 37% sensitivity. But if you put them in a controlled environment, you're upwards of 90-95% sensitivity. So you've got guys like the Ministry of Transportation that have decided to conduct their own trials on how cannabis and standard field sobriety testing works. So one of the tests in field sobriety testing is smooth pursuit of your eyes. So you know when you get your eyes go side to side and you get that nystagmus, which is this flicking of your eyes. That's great for alcohol. You know when you see googly eyes in somebody and they're intoxicated, you're like, oh, okay, you're gone. And their eyes start going, and you're trying to like go like this. And anyways, nobody's been there, huh? Okay, fine. I don't care. Never been there myself. But just saying. So what happens with cannabis? Just take a guess if I'm bringing it up. No guesses. So smooth motor pursuit improves because it improves muscle relaxation. That's what it does. That's like one of the main effects of CBD even. So not that matters for field sobriety testing because CBD doesn't cause euphoria, but THC does the same thing. So you have improvement in smooth motor pursuit. So nystagmus decreases. So they got smart, the Ministry of Transportation, and they changed it. They included cerebellar testing. So now they have hand to nose, and they have this thing. They added that to for field sobriety testing. When they did that, they got about a 97 to 99% sensitivity, which is awesome. So there is a way to test. They haven't done it in the field yet, and then they come up with all these other arbitrary numbers. They're trying to correlate, like using a swab in your mouth to correlate to some number. I do have a device that was used by that's used by NATO. It's this small mass spectrometer. It's actually portable. You know when you go to the airport and you stand in that thing? It's actually a mass spectrometer. So there is a way to test it. And basically, this German company came and said, "Can you figure out how we can use it for cannabis?" Sure. Took off the wand and I put on a hose, and it worked great. But unfortunately, we're still in the process of getting that sorted out. Eventually, we'll have a more accurate measurement. But it still doesn't matter. I can blow any number I want. We have to have something to compare it to. A number means nothing. And most of the numbers are just arbitrary that they're throwing out there right now. So we don't have a standard number. So let's go to the general let's go back. So overall, what are some of the general trends we need to know about neurocognition? So for the occasional user of cannabis, they have some disturbances across multiple cognitive abilities. What I can tell you is when it comes to cognition, and cognition is mostly defined by our IQ when it comes to using cannabis. So IQ plays a huge factor. Things like reaction time, things about like short-term memory, they're affected across the board. The judgment studies on is judgment affected with THC, the conclusion on those is no. And things like cognition and effect to actively conduct your business has to do mostly with IQ. Those with a lower IQ perform poor. Those with a higher IQ that use cannabis perform better. And there's about 20 to 30 different studies. I think I have them listed on here, some of them anyways. Now the frequent user, they're a little different. The occasional user has, like I said, has disruption across multiple different areas. The frequent user, they have decreased amount of disruptions across most of those functioning areas. They become tolerant to the negative side effects, but not necessarily to the positive side effects. Why? Because the negative side effects are mostly the same across the board. But I can change up the strains, and we can use different strains so that somebody no longer becomes tolerant to the specific cannabinoids or the specific entourage of how they're using those cannabinoids. So we just change it up. You know, one of the best things I do for patients, they say, Doc, I got to use I need 10 grams. Well, first of all, you don't need 10 grams a day. That's just ridiculous. And I don't care how you're using your cannabis. So, I mean, yes, if you're extracting it yourself and you're putting it into a concentrate, certainly, but you don't have to do that anymore. You can just go, get it, and it's legal to do that. You can get it from different, you can just get oils now. When you had to do that, I understood. I no longer have much, understand that so much. But what we used to see was patients coming in, Doc, I need to use 10 grams a day because, I just don't get the same feeling. Okay, stop using cannabis for 2 days. Your receptors actually reset fairly quickly. There's not much of a withdrawal period. You don't really feel much of a withdrawal. You may feel a little down for a day or two, but it's not very bad. And you're not going to die from it. And then your receptors are going to reset because that's what happens with cannabinoids. Or I got a better idea. Change your strain. So the positive side effects tend to not be as affected, and they still get benefit, whereas they become tolerant to some of the negative side effects. How about physical performance? There's actually a large body of research around this. Driving and performance tasks, of course, sensitive. Less morbidity, of course, than ethanol. We know that. Reaction time, short-term memory, I already mentioned that to you. And of course, confounding variables include age, ability, IQ, those kind of things. Bottom line, effects are short-lived, any of the side effects. Education is the most important thing. Don't drive a car if you're going to use THC. Just don't do it. I don't need somebody to tell me, oh, well, Doc, I drive better. How many people, I drive better when I'm high. I hear this crap all the time. Well, I'll tell you, some alcoholics drive better when they're intoxicated too. But we still have a generalized standard. I have patients that walk out of the emergency department with an ethanol level of 70 millimoles, and they're still walking. 70 millimoles to you and me, we would be probably dead. Not me, but you know what I mean, right? Anything over 30, you're probably going to be blackout drunk. But I got people that are able to walk out of the emergency department. Does that mean I'm going to say, go drive a car? No, of course not, right? That doesn't make sense. So at the same way, that's how we have to sort of explain it to them as well. The reason why we have these numbers, and this actually works, and this is an aside, this is just a clinical pearl. When people say, Doc, I'm able to drive, I'm fine. So that's when I go to the alcohol analogy. And I say, there's a lot of people, the reason we have generalizations is for the generalized public. It's for generalization. I'm not worried about you in particular. I'm worried about your friend and your friend's friend and everybody else in the world that thinks they're now going to be able to do it. So we have a law that sets a limit at X, because that's when the majority of the population has the problem. It may not specifically apply to you, but you're not above the law, so we still have to fall within the law. If you want, I guess these slides are going to go out. These are where the studies come from for all the side effects we sort of spoke about. So, I spent a lot of time on the risks and the negative side effects of cannabis. I do that because I think it's important to provide a very as unbiased opinion as you can. And you guys, as pharmacists, your job is to talk about the side effects when they come and you get the thing. I know, I go there, and you guys say, hey, do you have any questions about this medication? And yeah, so that's really important. So the side effects are really important because you can't, the indications are pretty straightforward. We know what most of the indications are. It's the side effects that we have to talk about. So what are my absolute, I guess as a last note on side effects, what are the absolute contraindications to the use of cannabinoids? For me, psychosis. That is like the number one, you know, for certain contraindication. My second contraindication is uncontrolled tachydysrhythmia. They need to go to a cardiologist and get cleared before they see us. That's my really only other one. Do I use cannabis in people under the age of 25? I do. I use it all the time in Dravet syndrome. I use it all the time in patients that are suffering from different spastic disease or neurodegenerative diseases. I use it all the time. And there's a body of evidence coming up to that point. Now, does that mean you're going to go out and recommend it? No. But, or are you going to go out and say, this may be an option, talk to your physician, or talk to somebody, here's an opportunity for education, because you're on 10 other medications and they're not working for you. Maybe this is the time to have that conversation. So, this I think was the nail, one of the nails in the coffins anyway, the Cannabis trial. This was done by Mark Ware in 2016. Looking at the difference between, and there's placebo controlled there as well, looking at the difference between risk factors between those who use cannabis and those who don't use cannabis with a non-cannabis arm and a placebo arm involved, or a non-cannabis arm involved. So there was no difference in the serious adverse events between both of those groups, those who used cannabis and those who did not use cannabis. Of course, and that we're talking about mortality rates, and serious side effects, like hemorrhaging, strokes, all the bad stuff. Now, medical cannabis users were at an increased risk of non-serious adverse events, but we're talking about headache and lightheadedness. That is not, those are non-serious side effects, but they were still there. So the safety profile of cannabis was definitely shown in this Cannabis trial. Of course, no difference in secondary safety assessment between cannabis and non-cannabis users. You should go have a look at this trial if you can. Done by Mark Ware in 2016. So how does cannabis help? Where does it help? Neuropathic pain, wrong one. Pain syndromes. Neuropathic and non-neuropathic pain. THC decreases pain intensity and improves analgesia. We know that. It does it in a couple ways. So through pain pathways, of course, but also glial cell desensitization. It helps through GABA, and it helps at the transient receptor protein. So not like neuropathic pain, where it's going to the CB2 receptor that's located on the on nerve endings, on the terminal end of the nerve. But in this case, you're looking at transient receptor proteins that are located at the source of pain themselves. So, for example, decreasing substance P. Mark Ware and Mary Lynch did a study. I think it was 2012. Looking at fibromyalgia and cannabis, suggesting that THC was better for those patients. It could be because you have an increased substance P at the location of pain in fibromyalgia patients, and THC can decrease that. THC, of course, is synergistic, as we mentioned, with opioids. CBD decreases cell signaling on nerve endings. We spoke about that. Any study, even if the studies, and I'll give you the list of them, you'll get them, the studies that didn't reach significance for pain, for example, they reach significance in one specific area pretty much every time. And that's around improvement and overall sense of well-being. You know, you have patients at their end of life. You know, it's interesting. I got called to the ICU. Oh, this kind of always makes me emotional. But, you know, because I spent 10 years trying to get people to prescribe cannabis. And about a month, 2 months ago, I got called by oncology at a hospital in Hamilton at the Juravinski Cancer Center. And I got asked if I'd go see a patient in the ICU and prescribe cannabis to a patient in the ICU. It was too late in the course of their care already. She was a 29-year-old female suffering from GBM, glioblastoma multiforme, which I think which hopefully will get some funding and do a study and cure that thing. But we actually got called by I literally, he's like, will you come prescribe cannabis? 10 years ago, they laughed at me. And now they're calling me to prescribe cannabis to a patient who's in the ICU. We had people in there that were like, why are you doing this? Why are you prescribing, why are you prescribing cannabis to this patient? And my first answer is, I have no real solid evidence. I've got case studies, I've got animal trials, I've got maybe 3 or 4 clinical studies showing that cannabis is helpful in GBM. It's actually one of the more pronounced, heavily weighted evidence areas is around GBM. But still, is it going to help her in her last days of life? Certainly not. In terms of, is it going to cure your cancer? No. But what it's going to do for you is improve your quality of life. Cannabis versus opioids. If you've ever taken opioids, they make you go to sleep. They bring you inwards. They make you recluse. You lose your friends. You lose your job. You want to stay home. You don't want to talk. Cannabis, on the other hand, does something very different. It brings you out. You go back to work. You start talking to your friends. You feel like you can move again, and you become more productive to society. That's what we find, and that's the overall sense of well-being that you get from cannabis. Significant in most studies, even when the endpoint of their study isn't significant. That's really important to take into effect, because it's not always about the curing of your disease. That's the old patriarchy talking. We're going to give you a pill, and we're going to drop it for you. Take the pill, it's going to cure you. This isn't a conversation. That's not even communication. Communication is, here's some evidence, you make your decision, and let's have a significant conversation. And if we have that conversation and you can improve your overall sense of well-being, medicine is moving towards functional outcomes. Functional outcomes are more important, in my mind and in the mind of a lot of my colleagues, than the curing of a disease. I don't care if you have a disease, if you feel good. I mean, I care, of course I care, I always care, but you know what I mean by that, right? So functional outcomes are super important. And that's one of the most important things that cannabis is good for. Inflammatory disease. CBD decreases inflammation response via cytokine signaling at the CB2, via CB2 activation. CBD, of course, is important for immune responses. THC improves GI motility. So the one area, there's 2 very good studies, by the way. Thinking of the dates. Journal of Gastroenterology, it was 2013 and 2015. I may be off with the date, but I'm definitely in the right journal. Looking at THC and Crohn's disease. Every area outside of the gut for inflammation is always CBD. If you're thinking inflammation, think CBD. But when you think about your gut, and you think about gastrointestinal tract, and you think of inflammation, that's where you got to start thinking about THC. THC, it was the opposite effect. It actually is an anti-inflammatory in your gut. So people that have Crohn's disease tend to improve with THC. Now, do they go into remission? Probably not. But again, the functional outcome is the important outcome that we're looking for. That being said, PPIs, massive side effects to PPIs. Magnesium all screwed up. We know if your magnesium's screwed up, it's no good. Do you guys see the side effects to PPIs? I'm sure you see the side effects to PPIs. THC is very good at decreasing gastric acid levels. You can use it, you can use it instead of maybe potentially PPIs. Tend to help people pretty good. Okay, Crohn's disease. We spoke about that. Spastic-related disease. So muscle relaxation, of course, again, via the CB2 receptor, improves smooth motor control via basal ganglia, all these areas in your brain. Talk about that. I think we spoke about that a little bit earlier on. And also, post-recovery, there's some good studies. Currently, we're only in phase 2 studies, so animal models, looking at collagen formation. CBD improves collagen formation post-workout. So I use it for athletes all the time. I use it mostly for its antioxidant effect and neuroprotective effects post-concussive syndromes. But and it causes muscle relaxation as well. But let's say you have muscle breakdown. What happens when you work out? I'll work out. Yeah. No, what happens? You break down muscle. That's what happens. That's what happens. You break down muscle. So what is your point? Your point is to regrow muscle. You got to break it down. You got to refuel the whole box. You got to make it all feel good. So what's a good way to get that better? You improve collagen formation. That's what you got to do. CBD helps with that. By the way, and it also helps with muscle relaxation. This is just an important note because you'll have athletes that come in there and say, can I use cannabis? And I'm an athlete. I'm a varsity athlete. I was team doc for varsity rugby for MAC from 2009 to 2017. I used to get this question all the time. Can I use cannabis? First, when I was working with the CFL, I was working with the Ticats. You know, when I started working in the CFL, we used to give the, I no longer do that. I only did that till maybe 2012. At the end of every game, we'd get, I don't know, 10, 11 guys coming in. Doc, can I get those home plates? Doc, Flexeril, looks like a home plate, right? Doc, can I get those home plates? Doc, can I get those T3s? Doc, where's the little baggie? This is all they wanted after a game. They come in, Doc, it's the home plates. They'll never, I love the home plates, Doc. Those little, the home plates. Can I get 5 or 6 of those? Over time, and this is at a time they still never test in the CFL. I'm like, just go home and smoke a joint, even though I'm not a proponent of smoking, right? We know that. But we're looking 2012. Vaporizing still wasn't big then, although I was pushing for it. I'd still rather them be addicted to or like hooked on a joint than addicted to opioids. A lot of them are addicted to opioids. Eventually, people stopped coming in. Eventually, people are like, yeah, I'm just going home and I got an edible here, or I went home and I smoked a joint, or I got a vaporizer, which I eventually convinced a bunch of guys to. And they stopped, and their opioid use started to go down. So I noticed huge trends and changes in that. But I always had a problem. We hear about the MMA and we hear about guys out there that were using CBD, and Chirag is a fighter, and he sees this stuff all the time. And so how do we use cannabis there? So you have guys out there like Nick Diaz who put their face in the game and post-game and post-match. He's been suspended for his behavior, and he'd be out there with a vaporizer smoking CBD. Well, I'll tell you, September of 2017, WADA, the World Anti-Doping Organization, and thereby USADA, which is the United States one, which we all seem to follow, took CBD off the banned substance list. So you can now use CBD during season. And that's amazing. So that's one method, and hopefully the NFL will start following suit, but that's one method to decreasing the risks of opioid use and the side effects thereof that's rampant in professional sporting arenas. Neuroprotection, we basically spoke about that. And then, cancer. When we talk about cancer, is cannabis prime time for cancer treatment? No, it's not. Can we get there? Do I think we can revolutionize the treatment of cancers using certain cannabinoids? Sure. In the future, I certainly believe it with proper RCTs and proper clinical trials. I think eventually we'll be able to get there. Are we there now? No. When patients come in or clients come in and they say, hey, I'm not interested in X, I just want to use cannabis and I'm going to somehow cure my breast cancer. Now, of course, there are some new studies showing that it's helpful, very possible, but is it your treatment of choice? No. The way I explain it is you have door A and door B. I'm going to tell you what's in door A. Door A, you have $10 million. Door B, you have $1 million. You have an option. You can take door A, door B, or take both. Which door do you want? Both. I'll take the 10 million and the 1 million. I'll take $11 million. So that's like your traditional current cancer treatment, and then your cannabinoids. Eventually we may get there, but we're just not there yet. So overall, general improvements in health. Can cannabis improve sleep? Yeah. Can increase hunger, improve weight gain, can improve nausea, can improve seizure rates in limited diseases. And those diseases we know are Dravet syndrome. They're currently doing a larger trial at sick kids on other seizure disorders. And we have Epidiolex that's now on the market. I see it all the time because it's not just in Dravet's. Even though the studies have showed Dravet syndrome, there are other pediatric seizure disorders where cannabis is helpful. Is it helpful in the adult seizure population? I think people used it as an excuse to get cannabis at a certain time. Do I think it's helpful in epileptic patients? I'm not convinced of it. I have a few patients that use it and they're on nothing else, so I'm okay with that. Mostly from a wellness perspective. I don't call it harm reduction because I think using the word harm reduction just on its own is a prohibitionist's mentality because it assumes we're trying to, protect you from harm. So I'm trying to, and that's not my goal. My goal is to improve your wellness and improve how your quality of life. So I use the word wellness prevention or promotion. So I think for wellness promotion, it's okay. So it doesn't improve lung function. Actually, your FEV1 improves. It's a bronchodilator. That was proven by Tashkin in 1997. Great studies that you should look at. And then, see, I say this word harm reduction here, but we're going to talk about wellness promotion. All right. So this is my research. It's not published data yet, and I just added this here today so that you can see it. I have a study that's ongoing. It's called Cannabis for Opioid Substitution Trial. And I put this one in here, and we're looking at patients who are using narcotics and are also using cannabis, and if they're able to come off of their narcotics using cannabinoids. I hear all the time, but it just does. It drives me absolutely mad when people tell me that we don't have evidence, because I just have to look at this one slide. And we're at an N of 588 here. We're at about 700 altogether. They answered this. This was the one of only, not everybody fills out the whole thing. But by approximately how much have you decreased your prescription opioid use? Over 50% of the patients enrolled in this study are 100% off their opioids. I didn't put over how long period of time, but 75% of them within 6 months. You can't make those numbers up. I'm not making them up. This is what the study is showing you. You have another 20% that are 75% off of their opioids. We have 80% of patients in this study that have decreased their opioid rate. You can't argue with the data. It's there. It's not published yet, granted, so people don't see it. Eventually it will be, and it's moving into an RCT, but you can't argue with this data. So cannabis is a viable alternative, and when people tell me there's no evidence, remember that first thing I said. Let's do no harm, then do everything you can for your patient. That's the most important thing we can do. Oh, maybe I did put this in here. No, that's old. Okay, so in summary, endocannabinoids, the endocannabinoid system contains 2 major receptors. We know about that. We spoke about the endocannabinoid system. It's got 2 receptors. We've got 2 of the ligands in there. Then we have phytocannabinoids in the external, the exogenous cannabinoids, and then we have the plant itself. The interactions between the endocannabinoids and the phytocannabinoids and our cells is a complex system, and we're continuously evolving. And it's an evolution now. It's no longer a revolution. And smoking cannabis is not good. We don't need to do it. We have other methods. And when we talk about what those other methods are, we talk about vaporization, we talk about ingestion. All of those are important. There are certain synthetic cannabinoids that are okay to use, including nabilone and including Sativex. And there are numerous ways to dose cannabis so that you don't have to get high if you don't want to. But remember, euphoria is not always a bad thing. There are some people that actually do quite well feeling euphoric, because at the end of the day, that overall sense of well-being is really important. Remember that CBD is important to decrease that euphoria and can offset any of the negative side effects that go along with the CB1 receptor. We have and on the safety profile, there's really no significant difference between those who use cannabis and those who don't use cannabis when it comes to severe and significant side effects. And that was done in the Compass trial. And we should take, of course, precaution when we're prescribing cannabis and understand that the message needs to be clear. It's not for everybody. You know, I look at a 5-person model. It works excellent for 2. It works okay for 1. It does really nothing for 2 others. But We have to do no harm first, and that's the most important thing we can do. I'm done. Thank you. And I'll take any of your questions. I love the clapping from the sleeping people. All right, questions? Yeah, fire away. Stop cannabis, and it's gone. Oh, and if they reuse cannabis, it sometimes yes. So if you stop, unfortunately, that's why I said compare it to like an allergy, even though it's not. You start using cannabis again, you're likely. Remember, it's your cannabinoid, the endocannabinoid system are master regulators of that bodily function. So for some reason, your auto-regulation of your cannabinoid system is dysregulated, and we don't know why yet. But you can't really start it again. That being said, you may be able to just use CBD. It's mostly around THC. All right, thanks, guys. Woo!
Okay, guys, we're running a little bit behind schedule. We do have that bus that's going to take us to Green Relief later on in the afternoon. So if everybody wants to grab lunch, and I think what we'll do is we'll probably restart about 5 to 2. You guys can grab your lunch, and then we'll take it from there, and we may start while you guys are eating. Okay, thanks.
I'll get you